Joe Brown.
Good afternoon. Thank you for joining our community discussion on substance misuse and overdose prevention. The opioid crisis in America has become a major concern in the last few years. Due to increased overdose events nationwide and our community, San Juan County Partnership has initiated response and a plan of action via the Opioid Misuse and Overdose Prevention Group. This group, consisting of experts and local organizations, will endeavor to make San Juan County a safer place in which to live. Today's goal is to offer educational resources as well as give the community a platform to discuss this very important topic. We will hear from two community members about their personal experiences with opioid misuse, then share partners' stats concerning opioid misuse and overdoses in New Mexico and San Juan County. After hearing the stories and presentation, you will have the opportunity to direct questions to our expert panel. We want to make very clear that we do not believe all opioid use is wrong. After all, opioids play an important role in pain management, and we are not advocating to doctors that they stop prescribing opioids altogether. We simply desire safe prescribing practices and want to ensure people are educated about the possible dangers of opioid use. Furthermore, if someone you know has issues with opioid misuse, we intend to provide resources for the next steps in getting them help, as well as open up a stigma-free dialogue. Now, we want to hear experiences from some local community members.
Bonita Kid. I am a recovering addict. I got involved with drugs when I was very young, at the age of 11. I lived overseas and there wasn't any real laws against any of that. When I came back to the States at the age of 13, I continued my drug use. By the age of 16, I was shooting IV drugs. I continued doing IV drugs for 8 years. I stopped and then I picked it up again at the age of 45. Throughout my 40-year spree on drugs, I did just about everything. Cocaine, methamphetamine, the different pills, just anything and everything as long as I could get more. I was always a fairly wild child. In school, I got a car early when I was 14, and that gave me the freedom to go out and ditch school and do all the things that I wanted to do drug-wise. Even though I was a young person, I could buy liquor at the liquor store at 15 years old. At the age of 16, during my second pregnancy, I was beaten up and raped. So I did put my son up for adoption. He was born with some multiple problems, cerebral palsy, and a couple other things, probably due to my drug use. I had him and I raised him, but I was a very angry, lost, and lonely young woman. And I think that started my life of crime.
Hello, my name is Catherine Phillips. I'm a recovering addict, alcoholic. I've been an alcoholic since I was 17. I've been a drug addict since I was 19. I've been in and out of jail and prison for half my life, 25 years altogether. My past is like, I was a loner. It's like I just wanted to fit in, so I was doing horrible things. I was 17 when I first went to jail. January 2018, I got credit fraud, a felon with the firearm charges. I went to jail for 6 months, went to the jail-based treatment access, and from there is when I started my life, because right now I'm looking at 18 years mandatory if I don't complete and finish my probation. I graduated Access and I completed it successfully. There's a women's church that I went to. I met a lady there. I have a lot of supporters behind me. She gave me a chance to work, and now I'm a shift leader at Church's Chicken, and it's pretty awesome. So I still have all my supporters even my family. And I would like to thank the Isaiah ladies. There's a lady named Sabrina and Tanya and Helen that I got to know very well that have been behind me since I met them. I want to say thank you guys for helping me. And my future is to keep going, be strong, and one day I want to be a youth counselor of substance abuse.
I was about 45 years old. I had gotten back into IV drugs. My 30-year marriage was dissolving, and I had managed to spend a lot of our retirement. I also had picked up multiple charges, many felonies. I am now a felon. At the time, I was looking at 10.5 years. I was given the gift of desperation as far as wanting to get clean. I knew I couldn't do that time in prison. So the judge told me if I could do 5 years probation and do a long-term treatment program, that, you know, I'd still be a felon, but then that I wouldn't have to go to prison. And a judge in Hobbs, or actually it was my probation officer in Hobbs, allowed me to move up here to my mother's in Farmington, and I attended the Access, at the time, the pilot methamphetamine project. It's still going strong. I attend their graduations, but whenever I was given the opportunity to go there, like I said, I had the gift of desperation, so I tried to soak up everything I could hear like a sponge, take what I could learn there, and it really helped a lot. I've got a lot of coping skills and tools now in my old toolbox to help keep myself sober and clean, because I also had quite a drinking problem. So when I got out of the jail-based rehab part, I started my aftercare. I got involved with the AA for a couple years. I still am involved with them. Then I found the rooms of NA. I love them. I've been very active in them since I discovered them. I am a sponsor. I have 5.5 years clean. And I sponsor people. I attend meetings generally 5 days a week is my average, especially now that we're opening up. I have people call me, probably 8 yesterday, just with questions. It's a hard time when people are struggling right now, and sometimes they just need a phone call and somebody to talk to. I give people rides to meetings. I don't do anything on a formal basis for pay or anything. That might be all right, but I really enjoy giving back, because when I say the rooms, I mean the rooms of NA, AA, and also the faith-based recovery programs around here. If I talk to people, I tell them, meet me in the rooms so we can get you started on step work and learning to get your life in order. The first thing is quitting drugs. Then it's about learning how to live your life. I did not know how to live a regular life because I was always on drugs and always drinking for 40 years. In there, through steps and readings and peer support, sharing your story, that's where we support each other and make it. Recovery is possible. It's not easy, but it's possible, and the rooms make it much more possible.
And people that are struggling, that has abuse, don't be afraid to ask for help. There's people out there that is willing to listen. I know it's hard. I know it's embarrassing that you're scared to ask. You think there's nobody like you, but there's everybody that is like you, that's in your shoes. Just one person will listen and they'll help you out.
One of our sayings in NA is, when you reach the end of the road, what is there left to do, with or without drugs? It can be hard to get off drugs because you don't know what to do. The first thing you should do is, we have meetings, we have lists, we have schedules. You can call people on these lists. They're willing to spend their time and their effort to help you if you're ready. like me, I have people call me from the rehabs after I go visit them, and you know, if they're ready and they're willing to do the work, I'm willing to do the work with them. But it has to begin with you, because nobody can get clean but you.
There are a multitude of similar firsthand accounts throughout our community. Our event page has links to additional stories from throughout the state, courtesy of the New Mexico Department of Health Another Way campaign. Now we want to share some data with you. Please welcome Athena Huckabee from Ideal Options as she presents important facts on the prevalence of opioid misuse.
Hi, thank you, Megan. My name is Athena Huckabee. I'm the Community Outreach Coordinator for Ideal Option, which is a medication-assisted treatment clinic that recently opened in Farmington on May 18th. We also have a location in Cruces that opened in April. I'm also a certified academic detailer and opioid subject matter expert with the Center for Health Innovation, New Mexico's Public Health Institute. And we can go ahead and start the presentation with slide 1. And then we can just move on to slide 2. I thought it would be helpful to give an overview of what opioids are. All opioids are medications that are used to treat physical pain. And even heroin, which we think of as a street drug now, was originally developed as a pharmaceutical. So I think it's important to know that history. It was marketed by Bayer Pharmaceuticals, and the word heroin was picked because of its similarity to the German word for heroic or strong. All opioids produce euphoria, antidepressive and dissociative effects, and stimulate opioid receptors in the brain and spinal cord. The important thing to know about opioids is that they're respiratory depressants, and this is actually what causes overdose events. When somebody overdoses on an opiate, it's not necessarily because it's toxic to the body per se, it's because it shuts down the respiratory centers and stops a person from breathing. Slide 3 is some examples of opioids. So for example, OxyContin or oxycodone, hydrocodone, such as Vicodin or Lortab, hydromorphone, such as Dilaudid, fentanyl of the prescription type, such as Duragesic or other patches, buprenorphine, such as Suboxone, Subutex, and Belbuca, codeine, such as Tylenol 3 or cough syrups, tramadol, such as Ultram, morphine, some brand names of that are Embeda, and others, methadone, then we've got illicitly manufactured fentanyl and heroin, and these are all examples of opiates. In slide 4, I just want to differentiate a little bit between dependence and substance use disorder or addiction. Dependence does not equal addiction or substance use disorder. Just because somebody has tolerance and withdraw, that can happen with many medications, such as antidepressants, anti-seizure medications. So to have a substance use disorder, people also need to have a loss of control, compulsive use, or other consequences. So I just threw this slide in to differentiate between chronic pain patients that take their opioids as prescribed, but might have tolerance and withdraw and not show evidence of other substance use disorder factors, just to again illustrate that we're not saying that opioids should never be used or that they're not sometimes appropriate, and that there is a difference between dependence and addiction. So just for a quick overview, moving to slide 5 of substance use disorder, again, to illustrate that tolerance and withdrawal alone are not sufficient to diagnose a substance use disorder. People need to have 2 to 3, 4 or 5, or even 6 or more of the symptoms on this slide to qualify for a substance use disorder. People with 2 to 3 would be considered mild, 4 or 5 would be considered moderate, and 6 or more would be considered severe. So I think it's important that we know the qualifications for a substance use disorder and what to look for. In slide 6, I just want to illustrate the opioid overdose impact in the United States. So an off-cited statistic that's very interesting is that the United States comprises about 5% of the world's population, but we consume about 80% of the world's opiate supply. And that includes both legal and illegal opiates. So that's sort of something to think about as far as perhaps how we think of pain in the United States. Are we over-medicated, or is the rest of the world under-medicated? Are there other factors that contribute to our, high consumption of opiates in the United States? Between 1990 and 2015, the drug overdose death rate in the United States tripled. So in 1990, we went from about 1.8 per 100,000 deaths being caused by drug overdose to 2018, where we had about 21.7 per 100,000 deaths being caused by drug overdose. I like to point out that what happened in 1996 that we believe that we know factored into this increase was the wide promotion and marketing of OxyContin for use for chronic non-cancer pain. Before 1996, opiates had not been approved to be used for chronic pain that was not caused by cancer. So a great article on this, if you'd like to read more, is The Promotion and Marketing of OxyContin, Commercial Triumph, Public Health Tragedy in the American Journal of Public Health, published in 2009. So where it sits now is that overdose is now the leading cause of accidental death for people under the age of 50. That's a citation from the CDC. And we're now statistically more likely to die from an overdose than in a car accident. So these are very real and sobering statistics, in the United States more generally. Moving to slide 7, this is just an illustrated example of how the opiate overdose death epidemic has happened in the US. So first we saw, again, with that approval of OxyContin for the use in chronic non-cancer pain, that our prescription opioid overdose deaths increased. Around 2010 or so, we see that people start to be cut off from those medications. And unfortunately, most doctors didn't understand the risks involved with simply cutting people off of their medications, and many people turned to heroin. And at that point, we saw a rise in heroin overdose deaths. Shortly after that, in about 2013 or so, we saw fentanyl enter the heroin supply. And so this is when we start to see the increase in synthetic opioids or fentanyl deaths, which also contributes to the opioid overdose epidemic. So just to understand that this happened in 3 waves, even though in the United States, generally, the overdose epidemic is not being driven by prescription opioids, that's where it started. Moving on to slide 8, the opioid overdose impact on New Mexico. So we're going to drill down here and look a little bit at how it's impacted New Mexico and then how it's impacted San Juan County. So between 1990 and 2015, the drug overdose death rate also tripled in New Mexico, going from about 7.5 per 100,000 deaths to about 24.8 per 100,000 deaths in 2018. Our New Mexico mortality rate as of about 2015 that we were at 24.8 per 100,000. In 2017, we're now at about 24.8 per 100,000 deaths being caused by overdose. And San Juan County is doing better than the state average, which is good news. Our mortality rate is about 16.7 per 100,000 deaths. But you can see that that's nowhere near what the rates were in 1990 when we were at more like 7.6. So it's still very high. I think it's also important to know that New Mexico generally has always suffered more from the opioid and other drug overdose impact. New Mexico was ranked number 2 in overdose deaths for many years. And things have gotten actually so much worse everywhere else that we're now ranked number 17. But as you can see, it's not because our numbers have improved overall, it's because it's gotten worse in other places and we look better now in comparison. So moving on to slide 9, just to illustrate again that New Mexico's overdose death rate has always been higher than the United States death rate average and continues to be at this time. I want to point out that moving on to slide 10, I want to point out that in the United States and in New Mexico, the things that are causing overdose deaths look a little different. So in the United States, we see that the opioid overdose death is being driven by synthetic opioids other than methadone. And what they're referring to there really is fentanyl. So fentanyl is really driving the overdose epidemic in the US. And you can see that that's the red line, and you can see how much that has increased in the United States. Here in New Mexico, fentanyl overdose deaths are increasing, as you can see by the red line, but as the orange line representing natural and semi-synthetic opioids prescriptions, or the blue line representing heroin, those deaths have always, again, been historically higher here in New Mexico than they have been in the US. And unlike the rest of the US, prescription opioids are still driving the epidemic of deaths here. So moving on to slide 11, we're just seeing here the top 10 prescription drugs that cause overdose deaths in New Mexico. The very top drug on the list is alprazolam, which we may know as Xanax. Second is oxycodone, which is unsurprising, a very commonly prescribed opioid. Third is methadone, which I want to make clear is not, we're not talking necessarily here about methadone clinics. We're talking about methadone as used for chronic pain. It's a very cheap medication. It's long lasting. It's available in tablets. It does contribute to overdose deaths in New Mexico. And we've got morphine, hydrocodone, buprenorphine, which is unusual to see on the list, codeine, which I was very surprised at because people think of that as very safe. Next, diazepam, which is a benzodiazepine or similar to Valium or Xanax. Then we've got clonazepam, another benzodiazepine, and then finally tramadol bringing up the list. I was really surprised to see tramadol on the list. That's again very widely prescribed, considered very safe, but contributes to the overdose death rate here in New Mexico. I think it's also very important to note that many of these may involve more than one drug. So people are often, overdosing and dying on more than one thing. And also to point out that 40% of overdose deaths in New Mexico involve alcohol. So that's an important point, always to make, is that when people mix their drugs is when it's especially dangerous. So just a couple more slides, moving on to 12, the opioid overdose impact on San Juan County. There have been 103 deaths due to opioid overdose in San Juan County in the 5-year period between 2013 and 2017. And it's led to 289 overdose ER visits in that same period. This is from the Department of Health, the New Mexico IBIS epidemiology website. So, and again, these are only the people that were reported. So people that did not go to the emergency room as a result of their overdose would not be included in these numbers. Finally, moving on to slide 13, the drug overdose death rate I want to compare what people are overdosing on in San Juan County versus the rest of the state in the 5-year period from 2014 to 2018. I think local data is so important. So we see actually that compared to the rest of the New Mexico average, not many people here in San Juan County are overdosing on heroin, but many people are overdosing on prescription opioids, and many people, as we know, because meth is such a problem in our communities, are overdosing on methamphetamine. Only a very small number are overdosing on cocaine, and also people are overdosing on benzodiazepines. I think it's a really important point to note that both in San Juan County and in New Mexico more generally, more people are overdosing on prescription medications than anything else. So if we combine prescription opioids and benzodiazepines and the overdose impact in San Juan County, that is by far the largest contributor. Again, even though methamphetamine and illicit drugs are problems in our communities. So there's the data. Thanks so much for paying attention. And I just have a few acknowledgements and on slide 14. And I thank you so much again.
All right, I'm unmuted. So this is what it's like to do a town hall in the age of COVID-19. So we're all figuring out this technology, but thank you so much, Athena. That was very well done and very informative and very helpful. So now I'd like to introduce our panel here. We have Mark Lewis from Southwest Care Center, Monica Ortega from Four Winds Recovery Center, Dr. Brad Campbell from the emergency room of San Juan Regional Medical Center, I'm assuming. um, here, because I didn't run that by you, Dr. Brad, but he is an emergency room doctor. So thank you guys so much for joining me. One of the first questions we had was, is opioid overdose really a problem here? But I think Athena answered that quite well for us, that most of our overdoses happen from prescription drugs. So we could move on from there. I'm going to direct this to Dr. Brad here. Are there other options besides opioids for pain management? And what are those options and how does that work?
Yeah, this is an entire conversation in itself. I mean, there's a big push. It's probably been in the last, I would say 8 years probably is when there's been a big push against opiate prescribing and opiate use, and gradually trickles its way into the emergency department. But our, what I call the college, which is what's called the American College of Emergency Physicians, I mean, they have an entire basically committee set up to alternative treatments instead of opiates. It's actually called ALTO. So it's alternative treatments to opiate care. And it'll go through a myriad of different things. I mean, and it kind of varies the type of pain. I mean, if it's true like neuropathic type pain, we have certain medicines called Lyrica or gabapentin. Those medicines, if there's some trigger point injections that people can do, they can actually, we can just inject the area with some numbing medication to kind of get on top of it. There's still patches, there's still topical creams. I mean, we use a whole other class of medications, which, I mean, there's some medications that are historically like some antipsychotic, which always have a bad stigma to them because we're using an antipsychotic medication for your pain. So when people Google it, they're like, what the heck is going on here? This isn't really a pain medication, but they've been studied like greatly and have a great like safety profile on them in being able to treat the pain. And those are medications such as Haldol, such as ketamine. So there's a whole like myriad of things that we're trying to get to. And that does not even include the like anti-inflammatory prospect or the anti-inflammatory medications, just the forms of ibuprofen for everybody listening.
That's great. Thank you for that. Again, very in-depth and very helpful. Now, when it comes to, obviously there are different ways that people come in with pain, and some of those pains are very short-term and very acute, but if we also have the issue of chronic pain and chronic conditions that involve chronic pain. And so in that situation, what are your suggestions when it comes to managing chronic pain? Say there is no other option, that opioid is the best option for you. What are some safety guards that we can put up for people? And I think that's a Dr. Brad question, but I also think that some of our recovery specialists too can buy in on that.
Yeah, I can start. I mean, chronic pain is, I mean, it's actually probably the primary driver behind like the opiate epidemic that's been going on is chronic pain. And then people such as myself, I mean, we get put into that, not put into it. I mean, we are part of that world of being able to treat chronic pain. I mean, we can bounce backwards in a little bit and talk about the acute pain process, which is a completely different topic, just like you just mentioned. But the chronic pain is, it's really more education. And the physicians, particularly like the emergency physician, realizing that we are part of that problem on basically promoting it. I mean, I can't think of a better word than just like promoting the continued use. And so it's really education to the patient individually each time, and being able to sit down and have the few seconds, I mean, to have that conversation with them. And a lot of times it really only takes us a few seconds to have that conversation, and that few seconds may make a huge difference in that chronic pain patient.
That's great. Thank you so much. Does anybody else on the panel want to address that question? Perhaps about maybe the safeguard side of that?
Hi, this is Athena. I would just want to mention that, I, as an academic detailer working with the Center for Health Innovation, work with doctors to talk to them about other options and how to prescribe opiates safely. Our main talking points are co-prescription of naloxone, only prescribing opiates, for the shortest amount of time possible, if possible, using other adjunctive therapies such as acupuncture and physical therapy and some other modalities. So if people are interested in working with an academic detailer, the Center for Health Innovation does that all over the state. It's a free service that's provided for doctors. So any doctor or prescriber, that would like to know more about that safer opioid prescribing, the Center for Health Innovation can help.
Thank you. Anybody else? Monica or Mark, do you want to buy in on that question? Okay, cool. So as far as treatment, say we've already entered the addiction and dependency stage of this, what are the types of treatment options that are available?
So I know that, well, I work at Four Winds. We are a residential treatment center here in Farmington. We also have an outpatient program. Most of the treatment facilities here in the area are outpatient. So they'll do intensive outpatient, or they'll do aftercare, also known as OP, or outpatient, regular outpatient. We also have, now we have 2 options for the medication assisted treatment. So there's Ideal Options and New Mexico Treatment Center, or I think I got their name wrong. So there's different options. Some people will struggle, like for example, Four Winds, we're a Minnesota model. So we do complete abstinence. So our clients who come into residential treatment are not on any drugs, no alcohol. And that does play into working with our community. So we'll have a lot of clients coming from the MATS programs, the medication assisted treatment programs. When they're struggling to taper down and quit, sometimes they'll come through us for that final push. And then we will refer clients back out into the community to the regular outpatient or the IOP programs. We also here at Four Winds, we try to work with 12-step programs. So we have AA and NA meetings that typically come here, and we try to work with the community as much as possible in helping clients figure out what the best mode of treatment is for them and what will help them long term.
Thank you.
And then, yes, hi, this is Athena again with Ideal Option. So Ideal Option is a medically assisted treatment clinic where we see people for opioid, alcohol, nicotine, really any chemical dependency disorder. And we have addiction medicine professionals that consult with the person and come up with an individualized treatment plan for everybody. I think the great thing about our model is that we see all patients within 24 hours. We accept walk-ins during our open hours. And we also network with behavioral health professionals in the community so that people are not only getting the medication assisted treatment from us, but also counseling and therapy, from other providers already working in the community. And yes, the methadone clinic, New Mexico Treatment, they do great work as well. They have a daily dosing program where people can walk in the morning, and my understanding is that they can get into the program if they have room for them, which they usually do. And Ideal Option and the methadone clinic have a cross-referral relationship, which is great as well. So if one thing doesn't work for somebody, they can try something else.
Thank you. Mark, I'm going to direct this at you. Some of this has been more Farmington focused. I know that you are at least a city commissioner in Aztec. Can you tell us about some of the options in Aztec?
I know there are NA and AA groups going on in Aztec right now. As far as treatment options, I'm not aware of any per se in Aztec proper. Most people come over to Farmington.
Great. So also you do work for the Southwest Care Center, and I was discussing before we actually started this program about Narcan. What is Narcan and how does one receive Narcan? Because there might be some questions about prescriptions or cost or insurance, and there's just a whole host of questions people might have. So first, and any of you can answer this question, what is Narcan? How is it used? And how do we make sure that we have it in our reach if we need it?
I can start with that. First of all, as part of our program at Southwest Care, we have what we call a harm reduction program, which is sponsored by the state and provided by the state. We're one of two sites in San Juan County. We do syringe exchange. So if somebody is injecting, they can come to us and we can obtain new syringes, and we take their used syringes and dispose of them properly. And interacting with them that way, we're able to help to address some of the needs that they may have, whether it be referral to rehabilitation, or even just sometimes it's just safer ways to inject until they're ready to start talking about rehab or quitting. And we don't want to drive them away by trying to lord that over them, but we do have that option. We do talk to them about it. But and one of the things we do is we have Narcan available, and we do distribute it. It's free, and there's a short training that goes with it. It's very short, like 20 minutes. That basically what that does is, how do you respond to an overdose? It's, what are the do's and don'ts? Some things you don't do, like don't do chest compressions if you're trying to keep them breathing because their heart's still pumping. Like as was mentioned earlier, it's a pulmonary thing. Do not inject other substances, things like that. So that's always been very helpful. And how do you tell if somebody's actually overdosing or just, as they say in the vernacular, nodding? And so we'll go through that with them. So it's been very successful at first. We've been distributing quite a bit of Narcan, and we've had many repeat customers, so to speak. So when you mention stats, we do have quite a few of our exchangers come in who said, oh, well, we used the Narcan last week. We had to use 4 hits because they wouldn't come out of it, so on and so forth. But it is being used, and people are learning how to use it, and we continue to distribute and teach others. So I think that's important to note too. And then I think that's been helpful. I think it's saved a few lives. And
Sure.
By the way, one quickie, our program has been in existence, or the state law that mandated our program, and it is mandated by state law, since 1997. And the Good Samaritan law, which you referred to earlier, that's been in place for quite a few years as well. So those are all good things to know and to keep in our back of our heads.
Absolutely. Athena, just real quick, because this kind of piggybacks on what Mark was saying about harm reduction, because we did get a question from the viewers about, does San Juan County have a clean needle exchange program?
Yes, and so as Mark said, you're going to go see Mark at Southwest Cares, and I think it's really important to know that people that participate in syringe exchange programs are 70% more likely to enter treatment. That's a statistic from the CDC, so you can find that on their website. So for people that feel that this is enabling in some way, or that it's not a good idea, it's a wonderful way to engage people, and I think that it's incredibly important. Also, just in case people didn't catch it, Narcan is the opiate overdose reversal drug. So if we give it to somebody experiencing an overdose, it will reverse the overdose. There's a state law now, SB 221, that requires that the Narcan, or naloxone is the generic name, be co-prescribed with any opiate prescription 5 days or longer. And sometimes, especially our people on Medicare, on fixed incomes, might have a hard time paying for that. It's important to know that they also can go see Mark and Southwest Care Center to get that Narcan if they need it. It's available for our whole community, not just people that are using drugs.
That's right. That's right. And Dr. Campbell might be able to confirm this, but is it standard practice that when doctors prescribe opioids, they also put in a prescription for Narcan?
Yeah, actually, like, to just couple on what Athena just said, is it's mandated that if you write the prescription, actually, I thought it was 3 days. So, man, I might have to write less prescriptions for Narcan. No, just kidding. But yes, it's mandated that if you write the prescription for greater than, like I said, I thought it was 3 days, must be greater than 5 days, you have to give them a prescription for Narcan. The thing that I see in the emergency department on seeing some of these patients, more commonly the chronic pain patient, is they refuse to fill the Narcan because of the cost of it. So they filled their prescription for the narcotic, and then they refused the prescription for Narcan, which is, their own prerogative to do. So knowing that Mark has available is another like resource option for me in the emergency department. Um, just a few other things on Narcan while we're there is anecdotally, I mean, it works. I mean, Narcan works per se, but anecdotally, the use of Narcan and having the availability of it works. During this whole COVID crisis, we've had a huge uptick in overdoses, and I think it's just it just has to do with the whole like pandemic process. And I've seen several myself, and I mean, there's 19 emergency physicians here in town, and I've seen several myself that were actually dosed up with Narcan by almost like a bystander, like a passerby that actually had to have some, that actually saved this person's life and made them to made the ability for them to get to the emergency department. So, I mean, it's a great drug. It's cheap. I mean, we mandate it to be in every like first responders vehicle that they have to have access to it and things of that sort. So it's around. So I didn't know it was around since 1997. Dang, thanks, Mark. But dang, that's dating me a lot too. But anyway, it's knowing that it's available and these people have it, and the stigma is going away from it. I mean, so the stigma is not there that when it's there, and you're not just the addict that has the access to the Narcan.
That's right. That's always very important to press, which is part of this town hall, of course, is trying to break down the stigma surrounding these problems that our neighbors face and that we ourselves might have faced. So, Dr. Brad, while we're still on you, one of the questions we had is medicated assisted treatment safe for pregnant women? Are there programs addressing substance use in pregnancy specifically?
Wow, I can't really answer that. I could send a text to a friend right now and see if I can come up with an answer. Can I phone a friend? It is there's going to be dangers to it, and then so you're going to have to weigh out the risk and benefits. The narcotic use through the mid pregnancy, through the second, third trimester is, I mean, I don't want to tell people that it's safer than the withdrawal, but the narcotic is safer at that point. And the narcotic is much more dangerous towards the end of pregnancy and birth, as well as in the first, like very first developmental side. So those programs, I mean, Athena may be able to speak to that a little bit better than me as far as like pregnancy goes.
Absolutely.
Yeah, absolutely. The American Society of Addiction Medicine, National Advocates for Pregnant Women, and many other professional organizations agree with what you just said, Dr. Brad, that actually that being on a medication-assisted treatment is much safer during pregnancy than going through withdrawal, and is actually the standard of care. So certainly we do, of course, want to see, that's a very responsible thing for a pregnant person to do, is to, realize that they're having some problematic drug use and to seek treatment through medication-assisted treatment, such as buprenorphine or methadone. At Ideal Option, we absolutely care for pregnant women, and I believe that they do at the methadone clinic in town as well. So that's very important to disseminate in the community. There's a huge stigma against pregnant women utilizing medication-assisted treatment, but it's the safest option.
Thank you. Monica, I'm going to direct this to you, Four Winds Recovery Center, because one of our questions that we received is how much of traditional and cultural treatment is implemented in these programs that we offer?
It really does depend on the facility. I know that we pride ourselves on being a multicultural facility, so we do incorporate traditional practices, and we're very culturally aware of our clients and what they may need in order to find the best treatment. And I think I would really like to say that in general, the facilities in this area, Cottonwood, Desert View, pretty much everyone has an idea of the population we typically work with. And so in order for us to work better with our community, we do have to be aware of things. So not currently at the moment due to COVID, but typically we would have our clients, they would have an option of going to Total Behavioral Health, which is another substance abuse treatment outpatient program, and they would do sweat lodge there. Or sometimes we might allow our clients, their families, to come in to do a traditional ceremony with them. It really is just client oriented for a lot of us, and we kind of have to acknowledge where we're at. And most of the people we work with are very culturally diverse, so we try to incorporate as much of their culture into our modalities to help them. So
Thank you. Any other panelists have a response on that? Mark?
About pregnancy?
No, about the cultural element.
Yeah.
Unless you have something about pregnancy, yes.
No, I don't. I'm sorry, I was listening to two different things at once. Well, first of all, yeah, culturally, we are seeing a lot of people coming in from the Navajo Nation nowadays who are, and it's illegal for them to have this stuff on the Navajo Nation. So they can, it's still in San Juan County, but they are on the Navajo Nation. But they, so we try to address things in a culturally sensitive manner. So I know that there's certain ways you address people, or bring things up to folks, and makes it, to make sure you're culturally sensitive in how you're discussing it with them. You don't want to make it sound like you're wishing them ill, especially in the Navajo culture. So that's one thing we do want to look at. I also wanted to point out, I'm not here alone. My coworker Joe is also a certified harm reductionist, and he's actually been the driving force in a lot of our efforts. That's him hiding behind me.
Hey, Joe.
And also the Department of Health offers the exchange as well at their place on Miller Street. But I wanted to point that out.
Yeah, that's very important. There's a lot of people might not know about harm reduction in general, and so I appreciate you bringing that to light, to the surface here. And this is the last question. We think we might have more come in, but are there any plans in the near future for more inpatient treatment centers? Was the question that we received.
So I know that. Oh.
Go ahead, Monica.
I don't know of any new programs that want to come in for inpatient or residential treatment. I do know that there are several in this community who are working on transitional housing, particularly for men. We already do have Masada House, a transitional program for women, housing program for women. And there's such a need for the men, for a safe place to go during or after treatment. That's a huge thing. And so there is some community members who are trying to work to a place where we have a men's transitional home, which is another part of recovery. But I haven't heard of anything personally on the inpatient side of things. I know years ago we did have other options. We have Access program, the DWI 28-day, and we have us when it comes to inpatient currently. But anything else I haven't heard of yet. Maybe Athena might know.
Well, I think that this is an important point thank you, Monica. I think this is important to point out where the difference between the services that we have available and what insurance will pay for, right, are different. So one of the reasons that there aren't many inpatient facilities in New Mexico is because Medicaid does not pay for inpatient treatment unless you're having a co-occurring mental health crisis. So you also need to be suicidal, pretty much, for and able to qualify for Medicaid to pay for inpatient treatment. And as we know, 50% of our population in New Mexico has Medicaid. So this is an issue where if people would like to see more inpatient treatment, they need to get involved and, contact their legislators, let them know that they want to see Medicaid dollars paying for these services. And then we would see more inpatient treatment facilities open. But as it is now, patients that want inpatient often have to work with a very limited scope of what they qualify for, have to pay, sometimes $3,000, $5,000 cash up front, or, have to have private insurance, which many of our people don't have. So It would be great to have more treatment, but the point is that Medicaid needs to pay for it.
That's great to know. Yes, Monica, you have one more.
I have something more to add to that. Payment for treatment is a huge deal, and that is one of the reasons why so many people will not seek out help. I'd like to just kind of throw this out there. Four Winds, we do not take insurance. If you are a New Mexico state resident, there's a program that we have with the state that will help make treatment affordable. So most of our clients will pay about $300 for a 30-day inpatient treatment here at Four Winds. We do work with clients on paying that. So they don't have to have $300 to come in here. They just need to come in here to get the help. And we work with our billing specialists, and they can make a payment arrangement so they can get very affordable treatment. No one has to worry about insurance, and we can get them to a place where we can transition them back into the community. And with the other treatment programs we have, outpatient, mental health providers, and other community providers that will help continue their recovery. So treatment can be affordable. And I think that that's one big thing about Four Winds is not many people know how affordable we are and how great of an impact that can make on your life and your recovery.
Thank
you.
That's great. And Doc?
Yeah, let me just spin this a little different direction as far as when people start thinking about inpatient services. A lot of times, I mean, we'll get this from the patient in the emergency department, is it's really a lot about the fear of the withdrawal. So they're wanting to have a quote unquote medical detox so they can get over the withdrawal of it from the in the supervised like hospital setting, versus that's completely different than a residential treatment center. So I mean, those are kind of two separate entities that I think get combined together a lot in people in their brain when they're thinking of their treatment. And so the actual medical withdrawal and detoxification in the in-house setting is difficult to find anywhere in several states that I've been in anyway. You can't get that done. It just doesn't happen very easily, and doesn't really have anything to do with payment, anything of that sort. As far as the hospitalization, it has more to do with services that are offered, and then that can kind of spin this a whole nother direction. I mean, I think specifically the local community who we're probably just speaking to right now, they need to understand the amount of services that you guys all on this panel have thrown out there and that are available to them, and that all are intertwined, and it's basically a good old boy club between all of these different services, and being able to help people pursue their treatment and be successful at it. I mean, there's a huge difference between pursuing treatment and being successful at it, as you guys all know. But all of these services that are provided here, I mean, you're giving them their best effort. So I think, I mean, I applaud your efforts from like my standpoint as an emergency physician anyway.
Absolutely. And this is a perfect segue actually into our final wrap-up question, which is, where can people get more information on all of these behavioral health services in San Juan County? Is there a sort of a one-stop shop where we can go on and see exactly what is provided in each of these areas? Where can we find that?
I think that the San Juan Safe Communities Initiative has an amazing website that Mr. Greg Allen updates regularly with all of the services in the area. It outlines hours, phone numbers, websites, information about each of those facilities or each of those programs. I personally have been using that, and there's a printable list. There's also the web page itself. There's links to all the sites or information there. But I've been using the printable list to give to my clients because it's been such a phenomenal one-stop shop information. So that would be where I would start, or where I would send anybody.
Very good.
I absolutely agree with that. And I think that if anybody, You know, we know that a lot of times people have to travel for treatment because programs may have wait lists. You know, sometimes it can take 4 to 6 weeks to get into something. And so people might want, you know, to kind of shop around. The New Mexico Opioid Hub, which is run through the Behavioral Health Services Division website, gives statewide resources on all of these as well. So, you know, sometimes our people do need to go to Doña Ana County or Santa Fe County or another county for treatment, unfortunately, as well.
Absolutely. Well, thank you so much to our expert panelists. We were joined again by Mark Lewis from Southwest Care Center, Monica Ortega from the Four Winds Recovery Center, Dr. Brad Campbell, emergency room physician, and Athena Huckabee from Ideal Options. Expert panel, you guys were amazing. Thank you so much for providing this very, very important info to our community. We appreciate it. And thank you to our panelists, but also thank you, community members, for your time and your questions. We hope to launch similar information sessions, both virtually and face-to-face, hopefully in the near future. As soon as that can happen, we want to do that. And so have a wonderful day. Again, we direct you to the San Juan Safe Communities website, the Public Health website, the San Juan County Behavioral Services website, the San Juan County Partnership website. There are so many resources out there. We hope that this has helped you. And again, we are stigma-free, and we want to keep opening that floor and keep pressing that point that this is not an issue to be ashamed of. This is an issue to work together on. Thanks again.